Hi, today we're going to talk a little bit about disc herniations. Disc herniations are one of the more common ailments you will see in your office, regardless of the practice you have. Any primary care physician will see a lot of these during the course of their practice. To understand disc herniations, you have to understand a little of spinal anatomy. Of course, there are two parts to a disc. There's the nucleus pulposus and the annulus fibrosus. The nucleus being the functioning part of the disc, more of the shock absorber. And then the annulus is kind of like the belts of a steel belted tire that contain the disc and allow for expansion and contraction. Annular tears are very painful in and of themselves, but do not generally result in any sciatica. Of course, an annular tear has to occur for a disc to herniate. And it's the disc herniation that inflames a bypassing nerve root that causes sciatica. It's estimated that 1 to 2% of the US population will experience a disc herniation every year. Disc herniations are far more common in men than they are in women, and they peak between the ages of 30 and 50. So what do we do when we have a person who comes in with acute low back pain, regardless of whether they have sciatica or not? Simple anti-inflammatory medications are often helpful. Getting them going on a physical therapy program can help as well. Non-steroidal anti-inflammatory medicines have side effects, and their effectiveness is questionable. They're better than narcotics. One of the best pain relievers is actually a Medrol dose pack because steroids really help calm down irritable nerve roots. The real question is, when we do these things and people don't improve, what are the next steps? That's predicated on insurance in part, but by and large, giving people a 2-week period of time to improve makes perfect sense. If they don't, then we need to get an MRI. Once you have the MRI and we can diagnose a disc herniation, how do we then manage the person from that point on, Epidural cortisone injections are commonly used to try and control pain. Physical therapy can be continued, especially if effective. All of these measures are done to buy time because most disc herniations get better without surgical intervention. And the question is really one of timing. So most surgeons generally don't operate on disc herniations in the acute setting. But when somebody gets to be 2 to 3 months out and they're not improving, then surgery becomes a more palatable option of treatment. There's one thing you always have to be concerned about with disc herniations, and that is the development of a Cauda Equina Syndrome. So you always want to take a very good history and do a very good physical exam, asking questions about numbness in their perineum or over their buttocks, doing a motor evaluation, looking for signs of weakness. Of course, those symptoms, a Cauda Equina Syndrome, markedly affects people's bowel and bladder function, specifically their sphincter function and their ability to control their bowel and bladder. If, in fact, somebody presents with those issues, that's a surgical emergency. They need to be worked up immediately, and they will need surgery, preferably within the first 8 to 12 hours. But by and large, that syndrome is very rare. We've touched on a few things we could discuss for days. The topic of disc herniations. Pearls to remember are normal discs do not herniate. Most discs herniate from simple things. Somebody bends over too quickly or twists wrong. A disc to herniate has to first sustain an annular tear. An annular tear minus a disc herniation generally gets better fairly quickly. If in doubt and you have questions, please feel free to give us a call anytime. I hope this was helpful, and you have a good day.